Hey, are you a new nurse in long-term care and every shift you are struggling and contemplating why did you make this decision? Well, this video is for you. Hey, my name is Nurse Key. I've been a nurse for 6 years and now I teach new nurses how to take this thing out of being a new nurse. So, this is part 5 of my long-term care orientation that every new nurse deserves. Part 5, we're going to talk about nursing rounds. If you missed any of the parts up until this point, go ahead and check them out on my page. But in this part, we're going to talk about nursing rounds. So in all areas of nursing, nurses should be doing the rounds at least every 2 hours and no shorter in long-term care. So nursing rounds is essential because this is how you prevent emergencies instead of reacting to them. You need to lay eyes on your patients just to make sure they maintain at their baseline. So you're not just laying eyes, but there's some few factors to consider every time you're looking at your patients. All right, so we're going to structure our rounds and not just have random check-ins. So first things first, I like the 3 B's. It's breathing, bleeding, and bowels. Breathing, is my patient breathing? Yes or no? If they are breathing, are they breathing at their baseline? No distress, no shortness of breath, and it's unlabored? Great. If not, okay, we have to escalate it. Bleeding, is there any bleeding or discharge that was not there before? If yes, escalate. Bowels, are they soiled and need to be changed? If yes, go ahead and change them, right? Also, with the medications, there are a few things that we have to assess before and reassess. That could be blood pressure. Make sure you know the blood pressure before you give blood pressure medicine. Also, blood sugar before you give insulin or a diabetic medication. You want to make sure that you're assessing it's the right person, the right time, your 5 rights, and their swallow safety, right? No aspiration risk. Pain medicine, look at their respirations, assess their pain level, assess their mobility first before you give pain medicine, and then reassess after to see if it was effective. Any refusals or missed those, sometimes you have to circle back and see if they need that medication or they change their minds, and document that they refused and what was their reason for it. If it's a frequent refusal, maybe it needs to be discontinued or the doctor needs to be notified to get that medication changed. Now, number 2, we're going to look at our skin and wound care. Skin meaning pressure wounds or pressure areas. That could be the back of the head, the elbows, the sacrum, your hips, and your heels. You'll look at those areas and make sure you're repositioning your patient every 2 hours. So again, in the other video we talked about repositioning, but we can go over it again. So repositioning, basically, if that person is flat or supine on the bed, that means their head, sacrum, and heels are all on the bed. You're going to turn them either to the left or the right, and that's a full turn. So all of their body weight is onto that side. Then you're going to support them with either pillows or wedges based on what your facility's policy is. So repositioning while you're doing your rounds every 2 hours to prevent skin breakdown. If they already have skin breakdown, you have to prevent further skin breakdown and make sure you're doing your wound care. Make sure the dressings are clean, dry, and intact. They're not soiled, or if you're doing incontinence care, go ahead and change that dressing. And you want to make sure you're reassessing the skin for no new areas of redness or skin breakdown. Then you're also monitoring their tubes. Is there oxygen in place as it should be? Many patients with oxygen in the nasal cannula is always taking it off. Make sure that their oxygen is on. If they have a JP drain, make sure that it's not overflowing. Same with Foley's. Foley should be changed when it's it should be no greater than 2/3 full in that bag, or else they'll overflow and it'll actually cause infection backing up the line. It should be below the bladder. The bag should not be touching the floor. And of course, make sure the bag is clamped. Peg tubes, if the feeding is supposed to be running, make sure it's running at the proper rate and it's not running on the floor. If it's IV running, make sure it's not running in the bed or running on the floor. Just little things to make sure what you put in place is still in place and is being maintained. Mobility and repositioning, we talked about that. Nutrition and hydration, you could go back around and reassess. Hey, did you eat your breakfast? Did you eat your lunch? Did you eat your dinner? If not, why? If you did, how much did you eat? Do you need any fluids? Have you drank? Have you urinated today? Have you had a bowel movement? all of those things. Yeah, you can add that to your documentation. You can follow up and have to alert the doctor, hey, this person has had a bowel movement in so many days. Can we give something extra if a PRN medication is not already prescribed? So those little rounds allow you to check in with your patients in between the medication pass if you have time, or during the medication pass, just to fill in the gaps of your charting and their plan of care. And then lastly, the hygiene and incontinence care. Doing your rounds every 2 hours, again, allows you to make sure that the bowels are taken care of, the bowels and incontinence piece. They're not soiled and their skin is dry to prevent future skin breakdown. So great nurses do not rush our rounds. We take our time. Of course, we only have so much time in the day, but we give our patients enough time to go through every task and make sure that we're checking every mark. But if you're just going kind of randomly, you don't have a structure, it's going to take you longer versus you have a system of assessment, a system of intervening with your patients and looking over them. It'll help you go through the day a little bit easier. So I hope that helps. All right, so we're going to go to the next part. Stay tuned. Welcome back to part 6 of the long-term care orientation every new nurse deserves. I'm your girl, Nurse Key, and I've been a nurse for 6 years, starting as a LPN, RN, and now I am in NP school. I started in long-term care, and yeah, enough said. So now I'm teaching new nurses how to be the best nurse possible. All right, so part 6, we're going to go over the common long-term care emergencies of why we send our patients out and what does that look like. All right, so in long-term care, emergencies do not just look dramatic, they start off subtle. In long-term care, emergencies don't look dramatic, they look subtle. So if you blink, you could almost miss it. Here are the most common long-term care emergencies and what you should never ignore. Number 1, change of mental status, right? So you're looking at your patients, you know their baseline could be possibly ANO times 4, or even they are a little bit nonverbal, but they are alert enough with touch, right? So that's their baseline. And then all of a sudden, a big red flag in long-term care or any healthcare facility is going to be new confusion, new lethargy or increased lethargy, agitation, which is not a baseline. And agitation is generally like non-purposeful movement. When they become restless, start pulling at things and you can't calm them down after like a short period of time. That would be a change in mental status. It could possibly mean infection, dehydration, medication issue, or hypoxia. Now with hypoxia, check, okay, well, you may not know it is that, but let's say that they wore oxygen and their nasal cannula is off. Okay, put their nasal cannula back on, check their oxygen saturation, or if they were on room air, check their oxygen saturation. You'll check their blood sugar, and you'll check your vitals. That'll kind of give you an idea of how to necessarily treat it. If the blood sugar is low, if they can swallow, do they need orange juice? Do they need peanut butter? Do they need glucose tabs? If their blood pressure is low, call the doctor, see if they have something ordered. Possibly they have Midodrine for low blood pressure. Do they need fluids? Hypoxia, do they need oxygen? Right? A confused resident is a sick resident until proven otherwise. Number 2, respiratory distress. Respiratory distress can look different in different patients, but the early signs, again, are going to be agitation, shortness of breath, work of breathing, right? They may be in tripod position, where they're bent over, labored, accessory muscles, right? Nasal flaring. And with all this, a drop in oxygen saturation, and they require more oxygen. So what you're going to do, you may sit the head of the bed up. You may apply oxygen if appropriate. May increase their oxygen demands. With COPD patients, you don't want to go above 4, but and sometimes in emergencies, you may have to, just depending on, but you'll check with your charge nurse or DON or the doctor of what they want you to do, and you'll notify them and prepare for a possible transfer. With respiratory distress, you don't wait for them to be blue. That will be a late sign. When they get lethargic, that's a late sign as well. Usually it starts with anxiety before you go into lethargy. Number 3 is going to be chest pain. Chest pain in long-term care is never really just anxiety. It's always a underlying symptom. and you have to figure what that could be. So chest pain will feel like pressure, tightness, radiating pain, nausea, or diaphoretic when they start sweating out of nowhere. It can feel like an elephant is sitting on their chest. And sometimes to differentiate chest pain between respiratory pain, you'll have the patient hold their breath. If the pain still exists, it would be considered cardiac. With cardiac, depending on your facility, you may have to do an EKG and run that and see if there's any abnormalities within that, or see if they have a history. Either way, you're going to call the doctor, report chest pain, and then see what they want to do. But when in doubt, send them out. Is usually the rule. Now, number 4, we're going to say falls would change the condition. Now, falls are in 2 categories. All falls are not equal. It's the fall with injury and the fall without injury. Also, fall with head injury as well. So when you see someone fall, or even an unwitnessed fall, you say, hey, did you hit your head? And then that kind of puts them in separate categories. So high risk sign is if the head was hit, or the head touched the ground with the fall. New confusion, anticoagulant use, right? Are they on heparin? Are they on Xarelto? Are they on Eliquis? And then if they have severe pain, deformity, or open skin, right? A fall plus symptoms is an emergency, especially with a head injury. You don't want them to go to sleep. You at least want them to have a CT just to be checked out, just to be safe. Number 5, signs of infection or sepsis. Infections present quietly in older adults, generally even like a UTI. One big sign is behavioral changes in older adults. So if they start acting off the walls and they usually are the sweetest person and they have a character change, that would be the biggest sign for a UTI. But other symptoms to watch out for would be a fever or a low-grade temp, right? 99 getting up to 100.1, 101. It's in that range. Confusion out of nowhere, almost like delirious. Poor intake, PO, food or water intake, and then tachycardic with a high heart rate. Those would be things that may show you an infection or even progress to sepsis. Older adults generally don't have fever spikes. They just decline in other ways. Number 6, severe hypoglycemia or hyperglycemia with the blood sugar. So blood sugar issues can turn pretty fast, and some patients are brittle, which means that they fluctuate pretty quick. They'll spike and then they'll drop pretty fast. So that's something actually to notate and report if it's if it's a known situation. Now, there are some, it's like hot and dry, sugar high, cold and clammy, need some candy. That's like a phrase we always say in nursing school. But other symptoms would include altered mental status. Sometimes they can be very agitated, but also they could be very lethargic. They could be diaphoretic, or they can be very weak or unresponsive. Now, if they're unresponsive, you already know that blood sugar has went too far to the extreme. But you'll check your sugar before you guess. So usually with status changes, again, you're going to check your blood sugar, check your vitals, just to give you like a gauge of like, could it be any of these that we have to resolve first and then work out. Because even when you report to the doctor, he's going to ask you what is the vitals anyway, so you might as well get just like a full set of vitals, check the blood sugar, and then report it if you have time. Number 7, acute abdominal pain. So new abdominal pain outside of like really just being constipated and diarrhea is not normal aging. If they have distension, if they're now guarding their stomach, which means like protecting it, they don't want you to touch it. If they're vomiting, any new vomiting is like a bad sign. And no bowel sounds. Could be bowel ischemia. Vomiting could be a small bowel obstruction. Guarding could be like a new that could be a lot of things, but we'll think like peritonitis. Abdominal pain plus changes need to be escalated. Now, when to send out. Now, this is going to be on a facility. They have their own protocol, but you're going to ask your 3 things of like escalating this condition. Is it a change from the baseline? Is the patient stable, or are they getting worse? Like if you give a patient that was hypoxic oxygen and at first they were fine, or it's not resolving the situation. Let's say you bump the oxygen up to 10 and the oxygen saturation is still pretty low. You need to escalate it. So there's things in your framework that you can kind of treat within your nursing scope, but if those are not if that's not resolving the condition, you have to escalate it to the physician or even transfer that person out of the facility. So is it a change from the baseline? Are they stable or worsening, unstable or worsening? And then can this safely be managed in the facility? Now that's the biggest thing. Some things just cannot be managed within the facility. So it has to be, the patient has to be transferred to a higher level of care. If the answer feels unclear and you're not sure, escalate it anyways. Let them figure it out. Whether it's your DON, your charge nurse, or the physician team, escalate it and notate that you escalated and what was the orders given or the response given. So long-term care nurses don't overreact. You have to recognize the risk early. All right, see you in the next part. Working in long-term care is not for the weak at heart. Medication administration is not just about speed, it's about control, system, and structure. Hey, my name is Nurse Key, and welcome back to the long-term care orientation that every new nurse deserves. I've been a nurse for 6 years, starting as an LPN, now RN, and I'm in NP school. Starting in long-term care is no joke, so I made this orientation just to help you along your journey. So this is part 7. We have 6 previous parts that we've done. They're on my page if you haven't checked them out. Now, part 7, we're going to talk about medication administration and time management. So, in long-term care, patients individually can have up to 20 to 30 medications at one time sometimes. So, it could be a little overwhelming, repetitive, and a lot of interruptions, and then time sensitive. So, if you don't have a system in place, it might be a little chaotic for you, and you're going to feel like rushed, under pressure, and overwhelmed. So let me help you out a little bit. So starting with the med card, right? Well, no, let's back up. Let's go to the MAR first. You're going to review your medications before you even get to the card. That way you know what to pull, what supplies you need, and what time it's already due. So when you give a report, you're going to sit down, look at your chart. Okay, I have this medicines for these patients at these times, and plan out your whole shift. That way you know which time clusters your medication pass is going to fall in, and at what times, if a certain room is the only one that has a medication ordered at a certain time, notate it on your report sheet. That way you know you won't forget, just in case your day gets chaotic. You'll have that in the back of your mind. So while you're looking at the MAR, you say, okay, the time critical medicines, who's getting insulin, so I know I have to check blood sugars, who has blood pressure medicine, so I notate that on my vital sheet, who's getting pain medicine, so I can ask them about it, and who tends to refuse. And if they have any special preferences, how they take their medicines, like pudding versus applesauce, we'll look at that too. So your brain needs a preview before your hands start moving, right? All right, so we're going to look at time sensitive. If everybody's getting medicines ordered at the same time, I start at either the back of the hall or the front of the hall, and I just go straight through. But if somebody has like a certain medicine at a certain time, then you have to go to that person first, and then I work my way through down the list just to make sure I don't skip anybody. Now, the only thing with long-term care in most facilities, unfortunately, they do not have a picture with the person's chart in that record, so you have to be relying on other staff members or their admission sheets to know if that person is who they say they are. Sometimes long-term care, the person could be nonverbal, they're not wearing identification bands, and they're not able to answer the orientation questions appropriately. So that is the tricky thing in long-term care settings. Now, not all meds are given equal, or not all meds are equal. So medicines like levothyroxine has to be given on an empty stomach. This is generally given at like 5 a.m. in the morning. Insulin has to be given before food, but within 30-minute window of food. Parkinson's medicines, antibiotics, and seizure meds are sometimes time-critical medicines that have to be given as ordered. Other than that, the routine medications are a little less dangerous to give around the time window. Generally, you can give medications an hour before or hour after the ordered time. Now, long-term care, expect interruptions, right? Because you have ratios as big as 20 to 40, and everybody seems to want their medicine at one time. But you kind of have to have tunnel vision, and like I said, you hit the back of the hall all at once and go up the hall, or the front of the hall and go down the hall. And you say, hey, I'm going to get to you when I can, and you just have to keep your focus and just work your way through all of your residents. Call lights, families, CNAs, and emergencies, you may have to delegate. Now, emergencies, you will have to go stop what you're doing and attend to it, but everything else generally cannot be disturbing your medicine pass. And some facilities even have a sign up say, hey, while the nurse is giving medicine, do not disturb, because it is a critical time, right? You don't want to make a mistake with too many interruptions. So it's kind of like you have to tune everything else out and focus on the task at hand. Again, also you're going to do one resident at a time, so don't pre-pull your medication. When you get to that name, pull the medication for that person, give it to that person. If they refuse, I say, hey, I can't come back and wait for it, because that's room for error. So if they refuse, all right, you're going to dump that medicine, usually in the sharps or the waste bin that your facility provides, and then waste the medicine. So be sure to prep for that person, give it to that person. That way you prevent medication errors. Also during this time, make sure that your CNAs can be doing rounds at the same time. That way they have eyes on your other patients while you're on the floor as well. They can tell you any changes that's happening, any call lights that need attending to, or anything like that. So teamwork definitely saves time and energy. All right, so handle your refusals correctly. So when people refuse medications, just depending on the person, sometime in the order will say that they're not able to refuse medications, but that's on a case-by-case basis. But let's say they refuse and they're alert and oriented ×4, and you've already explained the medications to them. You have to document it in the chart. Notify the physician that, hey, this person has refused this medication, and I have already educated them. But just document it. Don't argue with them. They have the right to refuse. And then just also protect yourself with documentation. I like to document my medications after I've given it, because I can say what was given, what was refused, and you don't have to rely on memory. So you could just chart as you go. Late charting will increase your risk of forgetting what was actually given. And then missed documentation altogether looks like missed care. So if it wasn't documented, it didn't happen. So all in all, a good medication pass is structured, and it's not rushed. It's kind of controlled, and it's under control. If you have a system, just in anything, whether it's medication or for your shift actually goes much smoother. So think before you actually just rush into your medication pass, and think before you actually just hit your shift in general. All right, so now part 8 is going to be next. Stay tuned.